Hi, everyone, and welcome to the show. I am live at the New Cardiovascular Horizons Conference in New Orleans, Louisiana, and I had the honor of watching a very powerful presentation at the event with Dr. Krishna Jain, a retired vascular surgeon who has an incredible vision for patient advocacy and improving the care for patients with a disease more prevalent and deadlier than most cancers. It's called peripheral artery disease, and it's blocked arteries and mainly the leg arteries. Left untreated, it could lead to heart attack, stroke, and amputation. My co-host, Dr. John Phillips, treats those patients. He saves those piggies, the patients who have peripheral artery disease, as Dr. Jain once did when he was a vascular surgeon. Now he's retired, still always a vascular surgeon, but now has moved into an advocacy role, writing books. John, I hear he has a brand new book he's working on to talk about the pillars of treatment for P.A.D. We'll have to ask him about that. But his presentation that really caught my interest at this event was about the disadvantages of Medicare Advantage plans. And so I would love to get into the discussion on that because I think it's going to be a real eye-opener for patients across the U.S. So
I am excited to have this conversation. I was supposed to be at that conference on faculty, but I was unable to attend due to my son's graduation, and I knew that this topic interests me in the sense that of late, and we've talked about this on the show, and I don't necessarily know what insurance plan it is, but I have noticed that we've had more denials of angiograms, which is the procedure that we do to take, look at the arteries. We've had more denials of CAT scans, and I actually had a patient that was denied a procedure because I didn't document that he had undergone the appropriate walking program before the procedure, but they failed to realize that the patient couldn't walk because the blockages were so bad. So this is a topic that I think is rearing its head in our country because of the costs that are just kind of spiraling out of control. And I believe that the insurance companies might be using this to help curb some of their overhead costs. So I'm looking forward to having a conversation with Dr. Jain, and I really want to pick his mind as to how we're supposed to understand not only Medicare but the other insurances, and maybe some tips and tricks for us as clinicians to navigate these waters.
And so before we get into this real deep discussion, how about a moment of inspiration to kick things off?
Perfect. So I was listening to Bruce Springsteen on the way in, and I found a quote from Bob Dylan today that I think is kind of interesting. And now he says a man, but obviously this can be related to a man or a female. But he said, a man is a success if he gets up in the morning and gets to bed at night, and in between does what he wants to do. So I kind of like that. And speaking of doing what I want to do, today, before since we're recording this, I was rounding on a patient who's coming to see us for a second opinion. And again, it just like the advocacy thing, it's a head scratcher for me because his foot, he's got ulcers on his toes. Gangrene, it's called. So the tissue's dying or dead. The foot itself is red up until about halfway through, almost near the ankle. And he may lose his leg. And when I told him that, he was shell shocked. And I can't grip my arms around this in the sense that how is it that folks are still getting to this point where we've got black toes, we've got a foot that's red, and it doesn't register, like something is wrong. And oh gosh, and I know this is why you do what you do, Kim, and we support it. And again, looking forward to hearing Dr. Jain and his thoughts. So let's get into it.
I'm curious, Dr. Jain, just hearing what John is saying right now. I mean, you've retired from, everyday practice. Are you just shocked? I mean, I'm sure you saw this back then, but are you shocked that we're still seeing this today? That people are literally showing up with it?
No, absolutely. So actually, I did retire from clinical practice, but I'm still very involved in taking care of patients in the sense that So in the sense that we have a company that helps people open limb preservation centers. So I'm very involved with the doctors and the patients and the issues related to insurance, et cetera, et cetera. Actually, it has given me an even more deeper perspective in the insurance issues, because when you're in practice, you do day-to-day taking care of patients, and many of the other issues which are administrative don't necessarily always address. But now that I'm helping open centers which have wound care centers, as well as we call OBL, or office-based labs, or office-based endovascular labs, or ASCs, where patients can get their legs revascularized on an outpatient basis. So these issues have become even more pertinent in my life in terms of dealing with the patients, as with the centers that they get denied payment. So you talk about Medicare Advantage. One of the things I would probably say is there's a total misnomer. It should never be called Medicare Advantage, because if you realize it, so we have the traditional Medicare. When you turn 65, you can sign up for Medicare. I'm on Medicare. I'm past 65. So, and Medicare, we have a great insurance. People don't realize it, but how great Medicare actually is. So what the government did a few years ago to curb cost, created a separate system called Medicare Advantage. It should have never been called Medicare Advantage, because what it is actually is an HMO system created under the guise of Medicare. So with the Medicare, the rules that are followed by the government and the hospitals and the doctors and all the providers, how people get paid. In a Medicare Advantage program, so that the patients understand what it means, what happens is, an insurance company, for example, Aetna or Cigna or whatever, they get a contract from the government based on the number of patients going to see, and based on what is the comorbidity of the patients. For example, if the patient is very sick, they get per patient more money from the hospital. In Medicare program, that doesn't happen. I'm not from the hospital, from the government. And then what happens is, then they have their own rules. So now suddenly they have X number of patients. Suppose they have 1,000 patients, and they guys suppose got $10 million to take care of them. Now, once they got the money, they design the program, what they can do, what they can't do, just like a private insurance. So it's actually a private insurance, an HMO kind of insurance under the guise of Medicare. So the patients get totally confused. They think they're getting Medicare. They're not getting Medicare. They're signed up with the private insurance companies, and they basically set the rules to a great degree. Yes, they do have to follow some of the Medicare guidelines, but for example, pre-authorization, denial of care, all the other things that go along with just like with any private insurance, Medicare Advantage is able to do that. So they really should not call Medicare Advantage, because elderly people, some of them are not very well educated. Even the educated ones get trapped into, oh my God, I'm going to get all these other benefits and I'm still under Medicare. No, you're not under Medicare as the Medicare was designed.
Come up right here on the Heart of Innovation. We're going to find out more about the disadvantages of Medicare Advantage plans in just a moment. So stay with us right here on the Heart of Innovation.
Welcome back, everybody, and thank you for joining us. My co-host and our guest are live in New Orleans at a endovascular conference and cardiovascular conference. I am living the dream here in Columbus, Ohio, and we're continuing our conversation with Dr. Jain regarding, among other things, kind of the differences between Medicare and Medicare Advantage and some of the pitfalls. So before we went to break, Dr. Jain, can you explain to me why anybody would enroll in Medicare Advantage if it's so problematic? Or are people just like, why not just do Medicare? How do you get involved in Medicare Advantage?
Yeah, so the Medicare is easy. Once you turn 65, you apply for Social Security, or then you can sign up for Medicare. You have to sign up for Medicare. Got 4 parts to Medicare: Part A, B, C, and D. A is the hospital care, B is the outpatient care, C actually is the Advantage program, and D is the drug program where you get your medicine. So those are the programs. So now, what happens is, now that all these private insurance companies are getting tremendous amount of money from the Medicare to take care of people above 65. So under Medicare Advantage program. Now they're private insurance companies. So what they have done is they package it beautifully for marketing purposes. For example, Medicare does not give you hearing services, or eye services, or dental care. So those are the 3 services usually not covered under traditional Medicare. But the Medicare Advantage programs figured out that's a huge marketing tool. So they say, well, if you're on Medicare Advantage, you will be able to get eye care, you'll be able to get dental care, and that gets expensive as people get older, as all of us know. I'm wearing glasses myself, right? So the hearing. So this is a huge attraction for them. The second thing they talk about is that you won't have to pay Medicare Part B premium, or you won't have to do this. So they package in a way that is very lucrative for a person, especially with the minimal means, or when they retire, with the retirement income is not much. Many of these patients, as yours and mine, live on Social Security and they don't have much money. So anything that they think will cut down the cost of their care, which there is certain amount of care, certain amount of expense you have with Medicare, you have to buy some co-insurances, or so you have to buy some supplementals, as they're called. So with the Medicare Advantage, the companies will tell you don't have to buy a supplemental, but in the process, the question is, what are you giving up? I mean, ultimately, the insurance companies are there to make the profit. The profits have been phenomenal since the Medicare Advantage program came. So ultimately, how do they make profit? They make profit by denying care. At the end of the day, if a patient needs a procedure done, or a CAT scan done, or an oncology patient needs some specific drugs, they deny it. And by denying those medicines, the profits skyrocket. And there's very little oversight from the government, from the Medicare side, because they have given basically these contracts and these to private companies. So at the front end, it looks very good. Actually, some of my friends, very educated friends, went into Medicare Advantage, but when they had cardiac issues, they could not get an echocardiogram, or they had to wait weeks to get a cardiac catheterization. And the next year, they switched back to Medicare because they were just not getting the care. And I can talk from the would you like me to address from the physician perspective what happens when we have a Medicare Advantage patient?
Well, let me ask you this. So let's say I turn 65 for our listeners.
Yes.
And
Uh-huh.
is this correct? I either go into Medicare and maybe need a supplemental insurance, or I can choose Medicare Advantage. Is that kind of the fork in the road for these folks?
Yes.
And then, so depending on which one you choose, is coverage and cost and road bumps and things of that nature. But then are you in it for a year? And then after that, you can switch back if you don't like it, or how does that work?
Yeah, so you are in that for a year, at least minimum 1 year. So because of around October, November, the signing period opens up, and then you can re-sign into Medicare, or you can switch from Medicare to Medicare Advantage. But sometimes it is not always that easy. Sometimes the pre-existing illnesses may not be covered by Medicare, which we had 65, we had 10 pre-existing illnesses. And when you turn 67, you decide now you want to go from Medicare Advantage to Medicare, or vice versa. So there are rules. There are very specific rules which you need to check in your local. I'm not a total expert on that, so I will not comment. But there are specific rules that you have to follow to switch from one to the other. It can be done, but it's hard. I've seen many patients switch from Medicare Advantage once they realize that is not what it was touted to be. Switch back to Medicare.
So what is their option when they're with Medicare, and let's say they're on the budget, they're on that Social Security, very limited, can barely even pay the rent, let alone those extra drug charges and appointment charges and scan charges for co-pays and all the deductibles and whatever it might be. So how do they, if they have Medicare, I know John was mentioning there are supplements you can get potentially.
Yes, correct. So you have to buy supplemental insurance for Part B. Part A usually covered by the Medicare. Part B is with outpatient physician services, outpatient scans, outpatient procedures, et cetera. And then in that also, once you do that, there's a certain amount of deductible, which changes from year to year. It's about $300, or it changes. I will not give you exact numbers. But again, I'm not an insurance guy, so I'm just a physician who have dealt with patients and looks at this from a management point of view. So you have to have a certain amount of deductible. After that, it's all covered by Medicare. In
Why
Medicare
are you
Advantage,
so passionate about
you, pardon?
I didn't mean to interrupt you. A little bit of a delay, but I was asking, why are you so passionate about this? Was there, a certain instance, or, what was the catalyst for you, saying, hey, I got to do a presentation. I got to get the word out there on this to patients and to doctors as to what's happening.
Yeah, so there are reasons. For example, being a vascular surgeon, I have several practices that I deal with. And when they have done all the right things in terms of getting a patient who needs an angiogram, that is the dye test where you inject dye, you go into the groin, inject dye in the arteries, find the blockages and fix it. So what is called a pre-authorization process, in the sense that in every private insurance company has their own twists to the pre-authorization process. It is not streamlined. Then you do 1, 2, 3, and 4, and you'll get pre-authorization. So all of them have the different quirks in terms of their system. So anyway, suppose you have Aetna or you have United. So you go now have a patient who has an ulcer on the foot, or who has claudicating. Claudicating means then they're walking, and they walk 10 feet and they can't walk anymore because they don't have enough circulation, which is called claudication. The more specific symptoms. Irrespective of that, once we know, now we as a doctor, I have decided this patient needs further treatment. The patient has agreed to that. It's not just doctor deciding. It is a patient and doctor together deciding that the patient says, I need more treatment because I'm not living my life, or I'm going to lose my leg. So we reach that point, and when we reach that point, now under the traditional Medicare, I'll just go ahead and schedule what we call an angiogram or the dye test. And there'll be no problem with that. I just schedule it and take care of the patients and do whatever procedure is required. And I go ahead and do revascularize, means that bring more blood to their legs by whatever method we choose. Now that is a traditional Medicare. I just do that. Now if I have the same patient is under Medicare Advantage, now what I have to do is I have to fill out a form online and then submit it to the insurance company that this patient is having this symptom, this is what their age, these are their risk factors, and these are the tests that we have done. Now I have to wait. I have to wait sometimes a couple of days. Sometimes it can take a couple of weeks or longer to get approval or disapproval from them. And they come back and say, no, we don't approve it. Okay, why don't you approve it? Well, cells now submit more data. So we submit more data. Now it takes more time. And ultimately they said, no, we still don't meet it. We're not going to approve it. So then we appeal it. Appeal means then we say, no, I want to talk to somebody in your insurance company who knows about medicine, because a lot of these programs are computer generated. I mean, the computer says you're not going to do it because there's an algorithm that says that you're not going to do it. So now I appeal it. I talk to somebody, and this is called peer-to-peer review. Peer-to-peer review means if I'm a vascular surgeon, my peer is a vascular surgeon, not an oncology surgeon or a PA or a nurse practitioner. So it's a peer-to-peer review. So I'm supposed to have now peer-to-peer review. Now, what happens is when I got on the phone, I set up a time. Instead of seeing patients for an hour, I spend an hour talking to this person on the other line. I could be seeing a patient. I could be doing a procedure. So I'm wasting my highly trained vascular surgeon 1 hour of wasting time talking to somebody on the phone. Now, peer-to-peer, there are only 4,000, 5,000 vascular surgeons in the country, right? I'm a vascular surgeon. So there's not enough vascular surgeon to do peer-to-peer review. So I end up doing with a PA. I'm not saying that PAs are not good and nurses are not good, but they're not my peers. Okay, so the PA now says, no, sir, can't do it. Okay, reject it. Or sometimes they say, no, approved. Now, if they're rejected, then I go to the next level of appeal. Now, at that point, I may get a vascular surgeon to talk to, and then that delays the procedure further. And even then, they may deny it. Okay, so now we have a patient who needs something done, and I can't do it because the patient obviously can't afford it. They're in the insurance contract, and I can't do it. And believe it or not, Medicare Advantage has more denials as compared to, at least in one study, as compared to private insurance as well as Medicaid managed program.
Coming up right here on the Heart of Innovation, we're going to get those numbers, so stay with us. You don't want to miss that.
Yeah.
Welcome back, everybody. Thanks for joining us. We're continuing our conversation with Dr. Jain. And before we went to break, I had a couple of questions. You had said that Medicare Advantage has the highest kind of turn down rate for procedures or denials, more so than private insurance. But aren't these, so number one, my question is, these are private insurances, like they're the Aetnas of the world, but they're wearing a different hat that says, hey, we're part of this Medicare Advantage plan. So I want to make sure I understand that. And then my second question is it region? Does it vary by region? So, I mean, if I'm in the Midwest, I'm in Columbus, do I get a Medicare Advantage plan from an insurance company that's more regionally based that might look different than somebody that has one in Florida? Or are they all pretty much boilerplate, stamped out and very similar?
Well, in a way they are similar and in a way they are not. The reason being, but just remember that all insurances, health insurances, have to be approved by the state board. So every insurance company has to have their state approval. So if the state disagrees to certain aspects, they may have a different. The core may be the same, but some of the things around that may be changed. For example, a few states now, at least 6, 7 of them have passed rules dealing with Medicare Advantage programs. Like you have to give a reply within 72 hours. For example, in Texas, they have what is called a golden card, sort of, so to speak, you get, in the sense that if 90% of your you were able to get 90% approval rating from the insurance company. That means if you submitted 100 claims and 90 were approved, that means you get a gold card. That means you don't need to go through the approval process. Except that the irony is only 5% of the doctors match up those 90%. So it's still majority of the time you have to get pre-approval. So yes, the plans in essence remains the same, Medicare Advantage plan, but the states have a role to play because it's all need to be ultimately approved by the state insurance commissions.
And do they change more frequently from a year-to-year basis than other plans do? Is that, I was reading that I think a disadvantage of Medicare Advantage is these plans tend to change more frequently. Have you come across that, or is that not accurate?
Yes, absolutely. I mean, they make their own rules every year. So Medicare rules, everybody knows they're universal throughout the country, right? Once we are in a Medicare program, except the local determination, local whoever the insurance company managing it. But Advantage program, they tune it up every year based on how much money they're going to get from Medicare, because they have the profit margins they have to keep for the shareholders, right? So, but at the end of the day, if the Medicare per patient, they get Medicare Advantage from Medicare, from the CMS. From the government, they get the money per patient. Now, suddenly, if they decrease it, then they tweak their benefits for the patient, or they may have a higher deductible, or they may suddenly say, well, for the eye care, now you only get $75 instead of $90 you were getting for your eye exam,
I guess the other question that I have is, do they have more restrictive networks too? For example, my insurance plan, I can go to our main hospital, but then there are other hospitals I can go to. Is it more restrictive than Medicare as well?
Is severely restrictive. For example, that's why I'm saying it's an HMO model, so to speak. HMO is, very certain doctors in the network. For example, if you'll be flabbergasted to know, you may already have seen that paper, but 90 million people in this country, 90 million people in this country do not have access to a vascular surgeon. There are about 380 counties, there's no vascular surgeon. Okay, so if there are no vascular surgeon in your counties or in the area, you may have to travel. And where you travel, suppose for example, I practiced in Kalamazoo, Michigan, and we had many counties we covered where there were no vascular surgeons, obviously, and underserved. So now suddenly you come to my hospital, and if my hospital, the vascular surgeons are not in that network, so to speak. Now you can't get care. So now you may have to go 250 miles to get care. Now, not only that, suppose every doctor is not specialized in the same way. You need some more specialized treatment, and then your doctor may not be in the network. But if you're with traditional Medicare, almost 95%, I would say, I can't, or higher number maybe, participate in Medicare. So you can go to any doctor, you can change doctors, you can go to another specialist, you can go for second opinion. But the Medicare Advantage programs are severely restricted in terms of their participation. And many hospitals now actually are signing off Medicare Advantage.
Yeah, it's very frustrating. I mean, I'm on the front lines with patients across the country, and you speak truth when you talk about that shortage of vascular surgeons and these patients that are on the Medicare Advantage plan. I mean, they have to not only get the pre-authorization for procedures and tests and everything else, they have to keep going back to their PCP to get another referral and yet another referral and yet another referral to whatever, vascular surgeon. Meantime, they're sitting here with lifestyle limiting claudication that is quickly getting worse and worse and worse, to the point where they're ending up within months, with rest pain and even a wound that wouldn't heal, because they can't get into a doctor soon enough because of all of these delays, because of their insurance, and also in some of the communities in Central California where they don't have a vascular surgeon, literally maybe one vascular surgeon for 3 different hospitals that are all about 2 hours apart. And so they go to get the referral to that one vascular surgeon. Well, then that vascular surgeon isn't available at that hospital for 2 weeks. They go back to the primary care. We have to find them another vascular surgeon in the other direction. And it's just like this long, drawn out process, and the poor patient is suffering in between. And I'm curious, doctor, what is your proposal, for the government? Are you lobbying for these patients, on Capitol Hill saying, hey, guys, you got to do something about it? What can we all do to make changes or create the change we want to see?
Why she's our congressmen, our legislators need to be educated. One of the things I talked about my talk yesterday, we need to work with the local legislators, state legislators, as well as at the federal level. We need to educate them. They are misguided. Part of the problem is obviously the lobbyist money. The money talks. So I mean, the doctors' lobbies are very weak. Hospital lobbies are stronger than doctors' lobbies. Even they're not as strong as the lobbies by the insurance companies. So when the elections come, we're in the election season right now. When the millions of dollars of checks are being written by the insurance companies, how do we compete with that? But at the end of the day, what I used to do, and I would recommend all the doctors to do it, I used to invite my congressmen and my legislators spend a day with me in my office. We will get the patient's authorization that they can be present there, and then they saw firsthand what the challenges are. When they see firsthand what the challenges are, they're much more supportive. I don't have the money, just like the insurance company, to lobby, but I do have the power of working with the doctors, to working with the legislators to get in my office and educate them. And we need to spend some time to educating these. And they are well-meaning people. All the legislators who came to my office were very thankful that they were able to see firsthand what our challenges are. So we need to do a much better PR job working with our legislators. Yeah.
Coming up right here on the Heart of Innovation, we'll have more with Dr. Krishna Jain, retired vascular surgeon, but very active in fighting for patients across the country for improved care. So stay with us. You don't want to miss our next segment.
Welcome back, everybody. Thank you for joining us. Dr. Jain, before we went to break, you had mentioned one of your recommendations is to have your congressman come in and actually see what's going on. My question for you is, what percentage, in your opinion, what percentage of physicians or providers of care know the difference between Medicare Advantage and Medicare with supplements? Because I mean, honestly, I hear Medicare and I think it's kind of like the same umbrella, but clearly this is different. So isn't one way to maybe fix this to just raise the awareness that this is out there? Because I mean, this is news to me.
Well, so when it comes to teaching the physicians, we do a very poor job, because if you go to all the meeting SVS, whatever meeting you go to, you never really hear about the differences and what the challenges are faced. However, on a local level, on a personal level, it's becoming more and more obvious. When Medicare Advantage came a few years ago, I believe it was under Bush administration. I may be wrong, but I think it was. But when it came, everybody was, yeah, it's another Medicare. But now that we're seeing the denials, now that we are seeing the patients suffering, we are seeing patients can't get their legs revascularized or coronary angioplasty or get a cancer treatment. Now we are becoming much more aware, because it's now at a personal level. When you're spending an hour, a physician is spending an hour or two getting pre-authorization. Now people are much more aware, but I believe we still do a very poor job of, I think every scientific conference should have 2 or 3 hours of teaching physicians, because when you go to medical school, you go to 4 year, you go to undergrad, you go to college, you go to 4 years, a 4 year lifespan of college, medical school, residency, fellowship, etc., etc. We never really learn about the business side of the medicine, so this is part business side of the medicine, and we need to educate doctors better the difference, because most doctors don't understand the difference till they now start seeing the denial. This, oh my God, why is it happening?
Your daughter knows all too well about the impact. Your daughter is a physician. She's an oncologist, and she appeared in a documentary presented by, I believe it was the New York Times. Would you mind sharing a little bit of her story? It was incredibly powerful. And when you played that one clip from her during your presentation at the new Cardiovascular Horizons conference, which we are attending and going live from today, I literally shed a tear. It was very powerful.
Yeah, thank you. So New York Times did a print story on pre-authorization, and also did a video, actually, which I was not aware of it till she showed it to me. So my daughter is in oncology. She's an associate professor of oncology at University of Illinois. She's extremely she does a lot of work for patient care. And also, she also does a lot of work for rights for women in medicine. So they did this video where she talks about how her I get a call at least from her once a week. She'll say, "Dad, another patient of mine who needed a PET scan was refused because they only allow 1 or 2 PET scans a year. But this patient suddenly has changed and needs another PET scan or an MRI." And then she would call me, and that she talks about on this documentary, that video piece by New York Times, where the patients refuse medicines because as you know, many of you know, you may have had patients in the family who have had cancer of some kind. The chemotherapy is time bound in the sense that you cannot wait a month and a half to start treatment for lung cancer while you're waiting for approval from the insurance company for the Medicare Advantage programs, and even then they refuse. And then they say you can use an alternative. I said, but when I know this is the best drug for my patient, why would I not do that? And so it is. So if you have not seen it, is available online. I'm sure on YouTube. If you just Google New York Times and Medicare Advantage program, it'll show up. Or my daughter's name is also same as mine, Jain. If you go to Shikha Jain, Dr. Jain on New York Times, it'll show up on that. So I think everybody should see it. This is a very educational piece, emotional as well as educational. The patients will realize what actually goes on behind the scenes, because sometimes our patients get angry at the doctors. How come you're not
Yes.
doing this procedure for me? Yeah.
And I just remember that one story that she shared about a patient, and she actually told during the peer-to-peer, something to the effect of, when this patient dies, I'm going to tell the family whose fault it was.
That is absolutely true, because the doctors get sued for medical malpractice if they did something wrong or did not do something right. And the question in this case is the malpractice is not by the doctors, by the insurance companies, but they are behind the scenes. Nobody realizes that the doctors are doing a lot to a great degree. I mean, the insurance companies have become doctors. They have no training, but they decide who's going to get what treatment. How can that be right? How can that be right? I mean, when you go to your doctor and you together make the decision what is best for you, not the insurance company.
Do you find that physicians are, crying uncle, and they're getting beaten down with the denials and the peer-to-peers, where they're just saying, you know what, forget it. I'm not going to order this test. I'll order something else. And do you see that at all, or have you heard about that?
Well, the frustration is taking many different aspects, so many different roles. So what is happening is, for example, our doctors, so many are getting so frustrated that they're selling their practices, working for the hospital. Independent practices are dying because they don't have the time. So they think that the hospital system will be able to get those approvals. Now, the many hospitals in the process now have stopped participating in Medicare Advantage, because now the hospitals, just like in your office, you're employing people to get these approvals, etc. Now the hospital has to do the same thing. They're not in a special bucket. They just have more resources. Now they're spending 4 people getting authorization for these doctors. And now at the end of the day, the problem just gets magnified. So it is true. Many of the doctors, for example, especially claudicators, when we talk about claudicator people who can't walk, they just will tell the patient, I don't get an approval. I don't have the time to get approval. So you suffer. I'm sorry, but it is what it is. Let me talk about claudication for a minute, because one of the requirements in that is most insurance companies have a requirement that you should have a supervised exercise before patient can have a treatment or a revascularization. What is supervised exercise? Supervised exercise means you go to a place where a physical therapist or a doctor's office, somebody under supervision is providing exercise. Okay, so that's what supervised exercise is. Now, 90% plus of the patients in the country do not have access to supervised exercise. They don't, because there are not enough systems. There are not enough physical therapists or enough systems where they can get supervised exercise. So if they cannot get supervised exercise, what does that mean? That means the insurance companies will deny treatment for them, because they're saying, well, you did not have supervised exercise. So where does the supervised exercise originate? In some of the clinical guidelines that were created by Society of Vascular Surgery, from radiology, cardiologists, said that you should supervise exercise helps. But now the question is, how do you do supervised exercise? The insurance companies say, well, then like a written order, supervised exercise, 6 weeks. Didn't happen, or patient didn't get better. Now, if you have no access, what I used to do as supervised exercise, I used to do 2 things in my practice. I would tell my patients who were from the rural area, You know the trees. You have one tree to the one tree. Now, your goal is by 2 weeks, walk to the next tree. By 3 weeks, walk to the next tree. So it is supervised exercise, so being supervised by the patient himself or herself. So now they're gradually increasing their claudication distance. The other trick I used to use was, now everybody has a cell phone, right? So there are apps on that. We can tell you how many steps did. So I used to tell them, okay, I want to see a week when you come back, how many steps per day you did. Then I would say, okay, in 1 month, I want you to do twice the number of steps or whatever the goals we set. So that was supervised exercise in a way. But no insurance company accepts that. They want that because they know you will not get supervised exercise, so we can deny treatment. So there are so many tricks to the trade of insurance world that they can deny treatment. And unfortunately, what they do is the guidelines are not what you're supposed to do. The guidelines are just guidelines. Okay, they're not written in stone. You have to modify your guidelines to a patient. We do individualized care. We provide to Uncle Joe different from Aunt Betty, because they're different lifestyles, different things. We personalize that. We don't do it. Everything does in medicine. There's no black and white. There are a lot of gray areas.
Coming up right here on the Heart of Innovation, we'll have the final thoughts on the disadvantages of Medicare Advantage plans. So stay with us right here on the Heart of Innovation. Go away.
Welcome back, everybody. Just wrapping up our fantastic conversation with Dr. Jain. So, in your opinion, is Medicare Advantage, is it going to go away? I mean, like, is this here to stay? And if so, how do we get patients to potentially avoid falling into this trap?
Yeah, so one of the things that happens is, how do people sign up for Medicare Advantage program? So Medicare, you can just sign up yourself. You don't need anybody to be really pressuring you to sign into Medicare, because yes, you're 65, you sign Medicare. But the Medicare Advantage is really pushed by the brokers, by the insurance brokers, because they all get a commission if they sign up patients for Medicare Advantage. So when you'll get around September, October, you start getting all these letters, sign up period is coming, come to this conference, come to this, we'll have coffee, we'll have tea, we'll have this and that. So you go to these, and there are these basically insurance brokers, insurance salespeople pressuring you to sign into Medicare Advantage, but they get nothing if you sign for just plain Medicare. But if they sign for Medicare Advantage, they get a commission. So patients need to be aware of that. There are pressure tactics to join that, and they should have a list of questions. They should talk to their friends who are in Medicare Advantage, what good things are. I'm not saying it's all bad. We are talking about a lot of negativity. I'm sure there are certain good things also. Certain insurance companies will promote exercise, promote, as I said, eye care, dental care. There's some advantages, and that's why people get sucked into it. But have a list of questions from your friends and family who have been on traditional Medicare and Medicare Advantage, and ask those people who are making the presentation those tough questions.
I was going to say, are there any advantages to having Medicare Advantage?
Not that I can see, except some of these peripheral benefits that are not by Medicare. And the other thing is, some of the poor people with lower income are living totally of Social Security. You don't have to buy a supplemental with that Medicare Part B. In supplemental, Medicare Advantage helps you with that. They tell you not to buy any supplemental. So that does help upfront, where the cost of supplemental is not borne by the people who are on Medicare Advantage. So there is certain advantage financial, but the question is that then what are you sacrificing for that? And certain people can't afford the supplemental, so they will sign up for Medicare Advantage. I mean, I understand that. Yeah.
It's interesting. We have a patient that just called our Lifesaver hotline last week, who is living in a van in Southern California so that he can afford a proper supplement, because he has peripheral artery disease and coronary artery disease. And when he was on the Medicare Advantage plans, they denied everything. He wasn't getting the care he needed. And so it's really sad. It is at lower cost for these patients, but that's just the initial. Once you actually are trying to get care, you can't take care of you. So he decided to go to Medicare and then pay through the nose for a supplement, so that see the doctors when he wanted to see, whomever he wanted to see, and get the treatment that he needed. But that's what it costs. He can't afford an apartment. He has to live in a van. And that's really sad. Something needs to be done.
Yeah, actually, I saw one of the insurance executives quote saying that, oh, the Medicare Advantage is not going anywhere because people can't afford the supplemental. So we believe we are here to stay, and we can do whatever we want. So
And ultimately, it sounds like just it's capitated care on a very large kind of population-based platform, in my opinion, which I think this has been a fantastic conversation. You've certainly raised my awareness to be looking out for these things, and hopefully our listeners are now better informed to make the right decision when it comes to healthcare over the age of 65. Thank you so much for joining us, Kim. Before we go, real quick, what does your father have? I mean, he's over 65. Does he have straight up Medicare? Do you know?
He is very lucky. He was served our country and has TRICARE for life.
oh
And so he's definitely at an advantage with his healthcare, and we feel very, very blessed. So thank you so much, Dr. Jain. It has been incredible. Thank you for all your time. We appreciate your time, your knowledge, your inspiration. Thank you everyone for joining us. And Dr. Phillips, you're doing a live case right now to link
Yep,
in Germany, another
I'm
conference.
helping out. Yeah, we've got a case coming up in a little bit in Germany. So yes, hopefully it'll go well.
Definitely. Well, I appreciate you taking the time. Have a great week and weekend to everyone.